Hello everyone. In this lecture, I will be talking about imaging of the larynx. This is what we intend to cover. We will start with some anatomical concepts, discuss various imaging modalities, and then look at some pathologies using a case-based approach before we finally summarize. As you know, the larynx is very closely related to the hypopharynx, and together these extend from the tip of the epiglottis, or roughly from the level of the hyoid bone down to the bottom of the cricoid. The larynx essentially comprises of an outer osteocartilaginous framework, which is formed by the epiglottis, the thyroid, and cricoid cartilages, which are all unpaired cartilages, and the arytenoid, corniculate, and cuneiform cartilages, which are all paired cartilages. In addition, you have some muscles, fat, and neurovascular structures. The cartilaginous framework encloses and supports an inner mucosal layer, which is what is visible to the endoscopist. So on the mucosal aspect, you can see the epiglottis, the aryepiglottic folds, which are mucosal folds extending down from the epiglottis to the arytenoids. You can also see two other folds lower down within the larynx. These are the vestibular folds, or the false vocal cords, and the vocal folds, or the true vocal cords, which are the white bands seen here. In between the true and false vocal cords is a horizontal air-filled cleft called the laryngeal ventricle on either side. Let's look at some coronal images. Here we have a T1 weighted MRI showing soft tissues, and next to it is a 3D reconstruction of CT showing airways and only a mucosal outline of the airway. Some of the images in this lecture are taken from a review article that I've co-authored and published in Imaging in 2013. You can see the horizontal air-filled cleft or laryngeal ventricle, which extends laterally between the false vocal cords above and the true vocal cords below. These are key anatomic landmarks which essentially divide the larynx into different compartments. Everything above the laryngeal ventricle to the tip of the epiglottis is the supraglottis. The glottis is the level of the true vocal cords and is mainly composed of the thyroarytenoid muscle, which forms the bulk of the glottis, and the vocal ligaments. Below the glottis, you have the subglottis, which extends to the lower margin of the cricoid. Higher up on the airway view, you can also see the air-filled valleculae at the top in the region of the tongue base. And infralateral to these, you can see the piriform fossae, which are parts of the hypopharynx on either sides of the supraglottic larynx. Coming to the sagittal images, you have the same anatomic landmarks which define the supraglottis, glottis, and subglottis. You can see the free part of the epiglottis marked by the arrow projecting into the pharynx, and in front of that you have the base of tongue and the vallecula marked by the dot. In front of the fixed part of the epiglottis, you have the predominantly fat-filled pre-epiglottic space, which you see here. Sitting on top of the cricoid cartilages and forming the cricoarytenoid units are the arytenoid cartilage. You can see the triangular arytenoid cartilages here, which are sitting on top of the cricoid cartilage. You will also notice that the plane of the glottis is not exactly horizontal, but is angled inferiorly at the front along the trajectory of the vocal cords. So it is important to angle your axial slices in this plane when you are reviewing these images on a workstation. This is also roughly parallel to the lower cervical discs. We will now look at some axial slices on CT and MRI. If you take a cross-section through the level of the hyoid bone at the top of the larynx, you can see the free part of the epiglottis and the median glossoepiglottic folds, which is flanked on either side by the paired valleculae. A cut taken below this through the level of the mid-supraglottis shows the fixed part of the epiglottis, the fat-filled pre-epiglottic space in front, the aryepiglottic folds on either side, and further posterolaterally, the piriform sinuses of the hypopharynx marked by the dot. The small vertical arrows mark the posterior pharyngeal wall of the hypopharynx. A cut further down at the level of the false vocal cords shows the superior processes or tips of the arytenoid cartilages and the paraglottic space, which still contains fat, as you see here, marked by long arrows on both CT and MRI. Presence of fat in the paraglottic space tells me that I'm still at the supraglottic level. Also note that the thyroid cartilage is quite variably ossified on CT, with some ossified bits at the back, as you can see on this image, and some unossified bits at the front. And this appearance is quite normal. However, this can make interpretation of cartilage invasion sometimes quite difficult. The next axial slice is taken through the level of the true vocal cords or the glottis, also showing the anterior and the posterior commissures. This is perhaps one of the most important axial cuts, and there are some landmarks to identify this level. Firstly, you will see the cricoarytenoid joints at this level. Secondly, you will see a transition of the appearance of the paraglottic space, which was previously fat-filled in the supraglottis and now contains soft tissue, which is mainly due to the thyroarytenoid muscle. Also note the minimal soft tissue at the anterior and posterior commissures. The last image is taken to the level of the cricoid and shows a subglottis with hardly any visible soft tissue along the inner lining of the cricoid cartilage. Behind the cricoid, you have the postcricoid part of the hypopharynx and the posterior pharyngeal wall in apposition, two mucosal surfaces in close apposition, as you see marked by the long arrows. In terms of techniques, CT is the primary imaging modality and is really the workhorse of laryngeal imaging. It is widely available in most clinical settings. The other big advantage is speed, and this is critical in reducing movement artifacts. The new multi-slice scanners offer a very high spatial resolution and excellent multiplanar capabilities. You can now sit on a workstation and manipulate and reconstruct these images in any conceivable plane. CT is also excellent at depicting bones, cartilages, blood vessels, and to look for areas of necrosis, particularly within lymph nodes. Another big advantage of CT is that it can be combined with chest imaging, especially when you're dealing with cancer. At our institute, we use an infusion technique in which we inject 100 mL of contrast at 1 millisecond, followed by a 100-second delay before scanning. This provides us with an optimal combination of both vascular and parenchymal contrast enhancement. The scans are performed with arms down. For the neck, we instruct the patient not to swallow, cough, and also to breathe quietly and not hold their breath during the scan. Breath holding will result in adduction of the vocal cords, and you will see a closed glottis on the scan, which can make interpretation quite difficult. MRI offers good contrast resolution between soft tissues. It's essentially reserved as a complementary problem-solving tool for difficult cases, especially when CT findings are equivocal. This is important when we are querying cartilage invasion or extralaryngeal soft tissue spread of tumor. As you know, it offers a good contrast resolution. We have a dedicated larynx protocol with thin slices, a higher matrix, and a smaller field of view than compared to the rest of the neck. We use the standard combination sequences T1, T2, stir, and post-contrast fats at T1, including diffusion. The main disadvantage is that the scan can be quite long, and this can result in motion artifacts, so you need a still and cooperative patient for the scan. Ultrasound is mainly reserved for evaluation of lymph nodes in the context of cancer. It can be used to evaluate the larynx in some cases, especially in children where the cartilages have not yet ossified. PET-CT is not routinely used for cancer staging, but may help in decision-making when we are dealing with large or complex cases, especially when we are dealing with advanced disease and contemplating on curative treatment, for instance. Its main role, however, is in the post-treatment setting, and we use PET-CT as a standard of care after 3 months of chemoradiotherapy to evaluate response to treatment. It has a very high negative predictive value. We sometimes use it for assessing recurrent disease, especially when there's a strong clinical suspicion and conventional imaging is equivocal. As you know, PET has an established role in imaging of the unknown primary, but this is mainly in the context of head and neck cancer elsewhere, such as within the oropharynx. Hybrid PET MRI is an emerging modality, but the role of this is still in evolution. and is still mainly used in a research context. Dual energy CT has come up recently and is showing some promise, particularly in terms of defining margins of the tumor, as you can see on this paper by Lam et al. Another more recent paper by Kuno and group compared dual energy CT with MRI and demonstrated higher specificity and acceptable sensitivity of this technique. So this is something to look forward to in the future. A wide range of pathologies can affect the larynx, including neoplastic processes, infection, inflammation, and so on. However, the bulk of imaging is done for laryngeal tumors, especially squamous cell cancer, and therefore we will focus mainly on this area. Laryngeal tumors can spread in any direction. When assessing for craniocaudal spread, a tumor that crosses the laryngeal ventricle is described as transglottic. Therefore, if a glottic tumor extends to the supraglottis, it becomes transglottic, and vice versa. Tumors can also spread in the anterior-posterior direction, mediolaterally, extend to the opposite side, invade the cartilages, extend to the extralaryngeal soft tissues, or spread posteriorly to the hypopharynx. All of these things need to be carefully assessed. One also needs to know what the mucosal endoscopic findings are and whether or not there have been recent biopsies, which may influence the imaging appearances. You can read details about T-staging in textbooks and papers, but we will briefly discuss some key concepts here. For instance, in the supraglottis, a tumor that is limited to one subsite with normal vocal cord mobility is called a T1 lesion. Therefore, knowledge of subsites and vocal cord mobility are important. If a tumor invades more than one subsite or glottis, or a region outside the larynx, such as the mucosa of the tongue base or medial wall of the piriform sinus, but without fixation of the vocal cords, is classified as a T2 tumor. A tumor that fixes the vocal cords and or invades the postcricoid, the preepiglottic space, the paraglottic space, and or the inner cortex of the thyroid cartilage, which is classified as minor cartilage involvement, is classified as a T3 lesion. Whereas a tumor that invades the thyroid cartilage with penetration or through and through invasion and or extend to the extralaryngeal soft tissues is classified as a T4 tumor. Likewise, somewhat similar staging systems are used for glottic and subglottic cancers. It is important to note that whilst there have been major changes to T-staging of other head and neck cancers, such as oral cavity cancers, pharyngeal cancers, there have been no changes to the T-staging of laryngeal cancers from TNM7 to TNM8. The end-staging, though, has changed slightly. Let's look at some cases here. This is a patient who had a clinically T2 lesion of the epiglottis. The patient was referred for staging imaging, and on the CT you can see it's involving both free and fixed part of the epiglottis and bulging into the preepiglottic space. On this coronal image, you can see that the tumor is extending laterally into the left paraglottic space with erosion of the thyroid cartilage and further lateral extension. You can see that the tumor is extending also through the thyrohyoid membrane to the extralaryngeal compartment and invading the strap muscles. You can see the same findings on the axial images with anterior and lateral extension outside the larynx, which is not visible on endoscopy, and this is exactly why cross-sectional imaging is so important in staging. So what was clinically a T2 tumor now becomes a T4 tumor. This is another tumor clinically felt to be a T2 of the supraglottis. Here we have the CT images showing tumor involving the fixed part of the epiglottis and the preepiglottic space, so at least T3. However, there is also suspicion of laryngeal cartilage invasion and subtle extralaryngeal extension. An MRI was subsequently performed, which better demonstrated the diffuse thyroid cartilage invasion and also some extralaryngeal extension, as you can see by the marked arrows. Therefore, we have upstaged the tumor to a T4 tumor. The patient successfully underwent a curative laryngectomy, and these are the corresponding gross pathology images which confirmed our radiological findings of a T4 tumor. I'm very grateful to my pathology colleagues for providing me with these images. We learn a lot from them by correlating pathology with the preoperative imaging. The issue of cartilage invasion is extremely important, not least because it can be tricky and difficult to interpret given the variable ossification of the cartilages, but also because it makes a huge impact in patient management. A T4 lesion with through and through cartilage invasion and extralaryngeal spread will usually go for a laryngectomy, whereas a T3 lesion with only minor or inner cortex involvement will be a candidate for voice-preserving treatment, i.e. chemoradiotherapy. CT is generally considered more specific for cartilage invasion but is not very sensitive. On the other hand, MRI is more sensitive but less specific. In 2008, Minerva Becker and a group who've done a lot of work in this area reassessed their previously published criteria on cartilage invasion by MRI, and they showed that if the abnormal cartilage had signal that is similar to tumor on T2 weighted images and post-contrast T1 weighted images, this was considered as tumor invasion. On the other hand, peritumoral inflammation had higher T2 signal and higher contrast enhancement compared to tumor. This increased the specificity of MRI whilst retaining high sensitivity. Sometimes it can be difficult to differentiate hypopharyngeal from supraglottic tumors, especially when the tumors are bulky. These structures are very closely related, and here you can see a piriform fossa tumor, which is not just invading the cartilage, but also extending anteriorly to the paraglottic space in the supraglottis. Glottic cancers usually present early, mainly by virtue of change in voice, and these tumors are often very small and can be difficult to pick up on imaging. Here you have a small T1 lesion of the glottis. Lower down, there's a slightly more advanced tumor extending to the anterior commissure and contralaterally to the other vocal cord. It is therefore important to always correlate these cases, particularly of the small lesions, with endoscopy, as these tumors can be easily missed on imaging. And remember, the role of imaging is mainly to assess for deep spread. The small mucosal lesions can be better picked up on endoscopy. This is a more advanced glottic cancer. Here you can see a large, bulky transglottic tumor invading the paraglottic space on the left side, which is completely effaced. You can compare it with the normal fat-containing paraglottic space on the other side. At the glottic level, you can see that the left vocal cord is involved, with extension to the anterior and posterior commissures. The tumor also abuts the thyroid cartilage lamina, but there is no frank invasion and no evidence of extralaryngeal spread. So this is classified as a T3 tumor and was treated with chemoradiotherapy. On the other hand, you can see a large, bulky, soft tissue mass on both sides of the thyroid cartilage here with through and through invasion, making it a T4 tumor. You can also see erosion of the cricoid and arachidon cartilages at the back. This patient had a T4 tumor and underwent a laryngectomy. Sometimes the extralaryngeal spread can be relatively subtle, and tumors can escape out of the larynx without much cartilage invasion. Therefore, you have to look very carefully using appropriate window settings to pick it up. Here you see a small nubbin of tumor extending out of the thyroid cartilage notch with subtle cartilage invasion, which was subsequently confirmed on pathology, as you see this on these images. You can see it on the histopathology images here as well. So the important point here is that you have to look very carefully for extralaryngeal spread, as these tumors can extend outside of the larynx without frank cartilage invasion, such as through the cricothyroid or thyrohyoid membranes. All our cancer cases get discussed in our weekly multidisciplinary cancer meetings, which comprises of a number of specialties including ENT surgery, maxillofacial surgery, radiology, oncology, pathology, and so on. This helps standardize our care for these patients and also is very useful for feedback and learning. Post-treatment changes are very important to recognize. After treatment, the neck anatomy is distorted, and we need to know exactly what a normally treated neck looks like. These are typical post-radiotherapy changes with diffuse thickening of the larynx, submucosal edema, generalized fat stranding, thickening of the platysma, and enhancement of the salivary glands. This is a post-laryngectomy patient showing concentric thickening of the neopharynx with an overlying flap. You can see the additional post-radiotherapy changes with fat stranding as well. Very rarely one sees findings such as these. This is chondroradionecrosis as a complication of radiotherapy, and you can see the fragmentation and destruction of the cartilages with sclerosis and gas. This was a post-laryngectomy patient who presented with a palpable neck lump, and you can see the normal neopharynx on the cut lower down with the pectoralis flap, but on the other image taken to the top, there is an eccentric soft tissue mass arising from the anterior wall of the neopharynx, and this was compatible with the recurrence. This is another post-laryngectomy patient presenting with dysphagia, and you can see marked concentric thickening of the neopharynx, also in keeping with the recurrence. And this is a patient who had a more diffuse, dispersed recurrence in the context of previous radiotherapy, and these scans can be quite difficult to interpret. Therefore, PET-CT is sometimes done to differentiate these post-treatment changes from tumor. The recurrence was subsequently confirmed on pathology. Okay, finally, a quick word on some other pathology that we may come across in the larynx. So what do you think is going on here? These are images from two different patients who presented with a change in voice. Endoscopy showed a smooth and intact mucosal lining with some mucosal swellings. In both cases, you can see a heavily calcified mass which is centered on the cartilages. These findings are typical for chondrosarcomas of the larynx, and these are textbook appearances of these tumors. Occasionally, we come across massively bulky chondrosarcomas, which can be predominantly lytic, as you can see here, and these exhibit a very high T2 signal in contrast to the relatively low T2 signal we see with squamous cell carcinomas. Another interesting case here, this patient presented with a change in voice. He was a known case of malignancy elsewhere, and a body CT done previously had shown a normal appearance to the neck. On the later scan, you can see a lytic sclerotic expansile lesion centered on the cricoid cartilage. This patient was known to have disseminated prostate cancer and had presented with a change in voice due to a new metastatic deposit in the cricoid cartilage. Another submucosal lesion, which is relatively straightforward to pick up on imaging. You can see a predominantly fat-containing lesion on MRI and on CT, but with some additional soft tissue components. The final diagnosis here was of a liposarcoma. Occasionally, we come across vascular lesions of the larynx, which are clearly visible on endoscopy. This was a young infant with stridor, and the ultrasound Doppler showed a vascular mass which was filling the subglottis. It was quite hyperintense on MRI, showed avid enhancement, and the final diagnosis was of a hemangioma, a high-flow vascular lesion. This was another young patient who presented with stridor and had a similar vascular lesion, but this was centered on the aryepiglottic fold. However, you can see that there's hardly any vascularity on Doppler. There's no arterial vascularity on the MRA. It is predominantly hyperintense on T2 and shows modest contrast enhancement. This was a low-flow vascular lesion, a venous malformation. This is a lesion we commonly see incidentally on scans, a cystic midline lesion at the level of the hyoid bone and thyroid cartilage. It is hyperintense on both T1 and T2. It is embedded within the strap muscles, and there is some deep extension into the preepiglottic space. You can see it on the sagittal images as well, and the appearances here are typical for a thyroglossal duct cyst. A number of miscellaneous pathologies can affect the larynx. Diffuse thickening of the larynx can be seen with infiltrative and inflammatory conditions such as amyloid, TB, sarcoid, and even lymphoma. Cartilage involvement with laryngeal stenosis may also be seen with vasculitic conditions such as granulomatous polyangiitis, and can also be seen following intubation. Laryngoceles are superolateral extensions of the air-filled laryngeal ventricles, and these can extend to the paraglottic space and sometimes can extend outside of the larynx through the thyroid membranes, as you can see on the right side here. They may also present with submucosal masses on endoscopy and can also be filled with fluid, as you can see on the left side. These may get infected. Sometimes a small tumor can be seen associated with laryngoceles. This image shows a very tortuous internal carotid artery, such as the one seen on the right side, and this is indenting the pharyngeal wall. This was an incidental finding, but it's certainly worth pointing out in your radiology reports. Okay, a quick word on this important condition. This patient presented with a hoarse voice, and you can see some laryngeal asymmetry on the scan. What do you think is going on here? Okay, so the key findings here are medial rotation of the arytenoid cartilage, medialization of the aryepiglottic fold with enlargement of the ipsilateral laryngeal ventricle and piriform sinus. Also note, the ipsilateral vocal cord is thinned due to atrophy of the thyroarytenoid muscle, which is better seen on the coronal images. If you look here, there is atrophy of the left vocal cord or glottis compared to the normal right side, and the ipsilateral laryngeal ventricle is enlarged. These are typical appearances of a vocal cord palsy. This is another patient with a hoarse voice, and you will now spot the vocal cord palsy on the left side more easily, as discussed previously. However, there are some additional findings here. Notice the atrophy of the left sternocleidomastoid muscle. Notice the atrophy of the trapezius muscle lower down. You've also got atrophy and denervation changes in the left side of the tongue. So this patient has a combination of 10th, 11th, and 12th cranial nerve palsies. So can you now pick up the culprit lesion on these images? Here it is. This was a glomus tumor of the carotid space just below the skull base. This is another patient with a left vocal cord palsy, but the etiology was much lower down. Here we have necrotic lymphadenopathy in the aortopulmonary window from a lung cancer, which is taking out the recurrent laryngeal nerve as it loops under the aortic arch. So the learning point here is that when you're imaging a patient with vocal cord palsy, you have to cover all the way down from the skull base or brainstem right down to the chest below the aortic arch to include the aortopulmonary window. So to summarize, here are my top tips. Firstly, a knowledge of cross-sectional anatomy is absolutely essential. If you know the anatomy, the battle is already half won. Most tumors are squamous cell cancers. Think of other pathologies if the clinician tells you that this is a submucosal lesion. Remember, imaging is key for staging and in particular to map out the deep spread of the tumor, which is not visible to clinicians on endoscopy. CT is the mainstay of laryngeal imaging. Be aware of pitfalls. Remember that small mucosal lesions can be missed on imaging and are best seen on endoscopy. Assessing cartilage involvement can be tricky, as we have discussed, and post-biopsy changes can influence the imaging appearances as well. And finally, a multidisciplinary approach is very important for managing patients with laryngeal cancer. Thank you very much for listening.